Hello and welcome, everybody. Luke, maybe we could start with a quick introduction from you.
Sure. Well, first of all, thanks so much for having me. Super excited to be here to chat with you guys. So my name's Luke Farrell. I am currently a fellow with Better Government Lab at the University of Michigan and the Tech Talent Project. But in a past life, I was at the White House where I was leading our teams of the United States Digital Service, working on crisis response. And in particular, one of the teams I led was leading through the public health emergency unwinding crisis response with state governments. In addition to that, I was a senior advisor for technology and delivery on the White House Domestic Policy Council, where I got to kind of work across the full suite of the safety net in the United States and think of ways and work on ways to make it more user-friendly, more dignified for the millions of people who rely on it.
Thanks so much. And Nikita, perfect timing. Sorry for your WeWork Wi-Fi issues.
All
Would you mind
good.
would you mind doing a quick intro?
Yes, I'm Nikita. I'm one of the co-founders of Fortuna Health. We're a Medicaid navigation company, helping folks navigate enrollment, renewal, a lot of the rules, regulation changes, requirements to qualify and maintain coverage on the programs. So happy to go into how we partner with largely health plans and health systems. So not exactly in the style or type of work that Luke did, but perhaps unsurprisingly, when we first started the company, Luke's name came up many, many times. So I'm really excited to be chatting about this with him.
Yeah. And thank you again both so much for being here. I think so, Nikita, I'm going to start with you and then Luke, you can jump in. But catch us up for those of us who haven't been paying as close of attention as you two on how HR1 is changing the eligibility requirements and redetermination experience for Medicaid members.
Yeah, happy to. So HR1 or OBA, people like to use different terminology depending on, just their vantage point, introduced a number of new requirements, largely and specifically for the Medicaid expansion population and able-bodied adults. So typically when people think about Medicaid, they understand this, a lot of the program is for people who are low income. 100% of the FPL is for standard Medicaid, known as MAGI. Then during the ACA, there was actually expansion for Medicaid in over 40 states, known colloquially as MAGI expansion. So these are considered able-bodied adults. And so a lot of HR1 and specifically community engagement and work requirements is focused on that particular population to maintain 80 hours of work, community participation, volunteering, et cetera. As a part of that, there is certain exemptions and exclusions. So if, for example, you are a caregiver or you are medically frail, maybe you have children or you are a child under the age of 12, you, for example, are exempted and excluded from needing to meet that 80-hour standard. That is one, and I would say the core of a lot of the conversations around HR1 for Medicaid is really specific to that population. Already today, to be and qualify for Medicaid, you do have to meet certain income levels or certain medical frailty or maybe a medical condition that qualifies you and your household for the program. HR1 is an addition on top of now new requirements, new standards, new qualifications that families and households might need to make. There is a pretty short, I would say, turnaround time for states and territories to get their systems up to date on being able to ingest, verify, and approve or, let's say, deny people for Medicaid based on these changes. So happy to go into some of the details of the 6-month periods of also increasing recertifications for a lot of those folks. So every 6 months now, people would need to recertify, and that's also tied to community engagement work requirements for some of those populations as well.
Yeah, I'll just add really quickly to that. Nikita did a great job kind of the fractal complexity that now states need to deal with and actually interpreting the guidelines coming out of CMS, understanding the law, and then actually implementing it before Jan 1, 2027 is quite a tight timeline, like Nikita mentioned. And so there's an enormous amount of implementation work and even the weeds work that states are currently wading through to actually make sure that they communicate these changes to beneficiaries so they know what they need to do to keep their health coverage. And then also on the back end, make sure that they update their systems, their caseworker trainings, their front office staff to make sure that they're actually able to absorb this kind of enormous new change to how eligibility is determined in the nation's largest health program.
I want to double click on the challenge that you described there for both the members, the states, and the organizations that partner with them. I think, Luke, I'll first kind of pose this to you because you got a little preview of this during the public health emergency unwinding, where we suddenly had to do a bunch of new redeterminations. And so I'm kind of curious, it sounds like, okay, we just have to go and we have to do another round of determinations. But I think I know for a fact that in actuality, it's a lot more complicated than that. Can you talk a little bit about how heavy of a lift this is for CMS in the States?
Yeah, so I mean, I'll just index on a little bit of the public health emergency unwinding when we needed to renew coverage for almost 90 million Americans for the first time in 3 years coming out of COVID. And that kind of really highlighted just how burdensome the process of renewing your coverage is on individuals, but also on state governments and the organizations that support state governments who are kind of doing the heavy lifting of making sure that people are eligible for the coverage that they're receiving through Medicaid. So, I mean, if you think about it from the enrollee's perspective, it's a lot of learning costs are associated with understanding what actions you need to take, right? You need to actually learn that you need to redetermine your health coverage twice a year instead of one time a year. And so that might come through a paper notice in the mail, but maybe you've moved addresses twice since they've kind of the state has gotten your updated address. So maybe you never see that. Maybe you get a call or a text that you think is spam or you think is real. It's really hard to communicate to beneficiaries kind of what changes need to be made. And then you need to inform the enrollee, and the enrollee needs to understand kind of what actions they need to take, right? Like, what qualifies for 80 hours of work? Do I send in my pay stubs? Do I have to get my employer to say something? And do I qualify for a medical frailty exemption because of my chronic condition? Or is my chronic condition not one that qualifies, right? So there's a lot of kind of communications challenge that is going to put a lot of learning costs on beneficiaries, that frankly, a lot of people are going to lose their healthcare, not because they don't meet one of the requirements, but because they fail to take an action or they take the wrong action that's required of them. So I think that's kind of the burden on the individual is quite high. And also I'll add that like the composition of a household really matters, right? Maybe the parents no longer qualify, but the children still do. And that's not always clear to a beneficiary who might be losing their coverage. And then on the state side of the equation, the lift is enormous, right? So there's systems level change. So the health tech nerds will be familiar with a lot of this, but like actually updating your E&E, your eligibility enrollment system with new logic that actually can interpret the requirements, updating the front doors, right? So your portals so that people can enter their work requirement compliance. All of those kinds of changes, I think, are going to be quite burdensome on the state government as well. And that's not to mention the behind the scenes work of doing data matching to try to maximally qualify your beneficiaries and find exemptions for them where it makes sense, which we can talk more about, and I think is a really important strategy. But the burden is manifold on both state governments and on individuals, and I think that's why we're really worried about a lot of people losing their coverage.
Nikita, I think you and your company have a very specific perspective or unique perspective on this because you're working with the people who are closer to the patients than the state Medicaid agencies in many cases. And so I'm curious a little bit if you can talk a little bit about what Fortuna is doing and how that interacts with those complicated systems that Luke described.
Yeah, definitely. And I just want to +1, +2 everything that Luke said. The aspect of where we sit in the ecosystem is, closer to the beneficiaries, closer to enrollees, because we largely partner with health plans and health systems. So typically organizations that are in the communities in different ways on the front lines of helping and supporting people with their coverage. So a couple of things that we see. One, I think the enrollee perspective at scale. We see that at scale in a state that we're in, but also in many states. So what we end up seeing is not just the most common, let's say 10 issues that people run into. We see the long tail of issues that people run into. And there's a very, very long tail because all of the permutations for a household and for a family that exists. That is the reality for a lot of people that are on the Medicaid program. Or maybe, as Luke was describing, you have some folks that are maybe the adults that are MAGI expansion, then you have MAGI, CHIP, et cetera, within a household as well. So there's a lot of that awareness, understanding, and then action complexity. So we see that at scale. One of the interesting parts about seeing that at scale is, yes, a lot of things are done at the state and done centrally, but there are also many states that have their counties involved in administering and adjudicating Medicaid, over 20. So now you introduce additional complexity of what sits on the side of the caseworker, and every single county that has their own, not just tech systems sometimes, but their own leadership, their own operations, their own processes, tacit knowledge, all of that also needs to be gradually moved over and changed with the introduction of work requirements and increased recertifications. So Luke was talking about the systems and the technology updates there. Absolutely, there's a huge burden on that. And then now on the caseworkers, eligibility workers who bear that same costs, there is even more burden on those folks. So we have a lot of both seeing from the beneficiary perspective, the challenges, and then trying to work with and at least providing perspective sometimes to states or sometimes to caseworkers of what we do see. Because if you only see one case, you've only seen one case. Everybody says, you've seen one Medicaid program, you've seen one Medicaid program. I would say the same. If you've seen one Medicaid case, you've seen one Medicaid case, because there are so many. So I would say, like, as a company, that's what we see. And just to add on one thing, because Luke talked a lot about it, which is the communication burden. States are not, and I don't think they should think that they're doing this alone. I don't think states think that, but because you have health systems, or CBOs, or health plans, these are your partners in doing that communication outreach, doing that support. And I would behoove states, and I know CMS is also talking to states about this too, is take that network, a network that got activated because of the unwinding and PHE. We've done a flavor of this before, not the same thing, granted, but some of that underlying infrastructure exists, and that is, there to activate again with communicating some of the changes around HR1, what people need to do.
Luke, you wrote an article that prompted a lot of conversation, really great conversation in the community, called The Means Testing Industrial Complex. And that was a really well-timed article, because shortly thereafter, CMS made an announcement that I linked to in the show notes here about companies making pledges on Medicaid technology. I'm curious to get your reaction on, Deloitte, it looks like, made a pledge. Equifax was notably absent from the list. Curious for your perspective on what the current state of the technology landscape is, and what to make of this pledge.
Yeah. So, I mean, taking a step back, I think the point I make in the piece is that the complexity kind of personified by work requirements that we layer onto Medicaid creates a surface area for corporate capture, right? For players like Deloitte or Equifax to really kind of prey on the core machinery of administering the program, and the government kind of outsourcing that function to them, and then them kind of growing dominant businesses that are then very hard to compete with, and for others to compete with. And so I think one of the bright spots, right, is like some of the work that Fortuna Health is doing and others around how do we add more competitiveness to the landscape to make sure that there are new players that can be introduced that can provide really great innovations on top of the Medicaid tech stack that make it better for beneficiaries, make it better for staff, make it better for state governments, and make it better for taxpayers, frankly. But I think the pledges, I can't speak specifically to the kind of pledges that were made by either of those companies. I don't know kind of the details that are required. I saw the same press release that folks did as well. I think it's notable that there was $600 million to be saved as a result of work requirements implementation, right? This is like a multi-billion-dollar requirement set that they're placing on state governments through HR1. And so the fact that there's, a $600 million cost reduction, I think, is telling of just how dramatic these changes really are. I was glad to see that Deloitte was starting to acknowledge its role in being a good steward of taxpayer dollars. And Equifax notably did not make the same acknowledgement. But I think what I found most optimistic about the announcement was actually CMS calling people to the table to make these pledges. I think historically, CMS has seen much of its role as kind of cutting checks to states, writing regulations, and then letting the states kind of figure it out on their own with their vendors. And I actually really like a more consolidated approach at the federal level where we say, hey, like, we're actually going to have our states' backs in this, right? Like, we know states are all going through the same thing with the same handful of vendors, and we're going to have their back when they're negotiating with those state partners. And so I think CMS having a more forceful role in supporting state governments, I think, is really, really important. And this is a small step, but an important step, I think, towards a more expansive vision of what it means to protect states in their negotiations with big contractors.
Nikita, over at HTN, we were really excited to see Fortuna's name on the list. I'm curious to get your perspective on how progress is going with the MCOs and the CBOs and the health systems that you work with, and maybe also what you're hearing from states on, are they ready for January 1, 2027? What's the vibe like on the ground?
Yeah, maybe I'll just focus on the state perspective because it'll piggyback off of what Luke was sharing. But then the CMS directive is focused on states. I think that with the timeline and also the amount of support CMS is endeavoring to provide to states, this needs to be done by well, technically the outreach is going to go out to members and beneficiaries around October and November. So you better be ready by Jan 1st, 2027. I am also very grateful that CMS is doing a lot of work to, one, bring in innovation, but two, use its market power, as Luke was saying. You absolutely have, and Luke showed it in the article that he wrote, certain states are paying X amount of dollars for the same exact type of data that other states are paying a different amount on, and that doesn't really make any sense. It is extractive, point blank, period. There's no other way that I take a look at that as an innovator. So I'm glad CMS is acknowledging that, taking steps around that. We were mentioned amongst some other companies of CMS also acknowledging that procurement is a big barrier around this. One of the reasons you see a small group of players in the Medicaid technology space is the tax on states and the many steps that states need to take to get a procurement done is enormous. So CMS is acknowledging in the GSA schedule and bringing startups or smaller companies, innovators into an accelerated pathway is them saying, we acknowledge that there may be some lock-in that states have. And if states had more options, then if we do maybe some procurement reform in different ways, we're enabling states to make and have more choice in who they provide. There's still a short, I'd say granted a short timeline to make that happen, but CMS is definitely taking steps to say, here are more options for states. Can we help make that procurement pathway, that procurement timeline a little bit better? But that's only one of many things that need to happen because yes, you could accelerate a procurement timeline in certain ways, but states are also locked in how contracts are written. Contracts, if they're not done correctly, and it's actually why I think a lot of Medicaid directors and Medicaid leaders are lawyers. It's starting to see that trend over the last 10 years is the contracts that you sign, whether it's with managed care, honestly, but also with the IT that you use. If you're not looking at that with a fine-tooth comb, you could be taken for a ride. And as particularly with the underlying MMIS or E&E technology, as Luke mentioned, these are multi-billion-dollar contracts. It's not trivial to sign them. Data ownership, data protection, security, all of that needs to be done in a really thoughtful way. And by having more innovators, states have more options also to flex their power as well. It's not just 4 companies that you're dealing with. Now maybe, we have a Wellspring. Maybe there's 30 now that you can figure out, you can negotiate with, get what's best for, the people in the state that are on the Medicaid program, but also state and federal taxpayers who are all accountable for Medicaid.
Yeah, I mean, just to add on one more thing, Nikita, because I love that point you made. In addition to lawyers, you also need technical staff in-house inside of government who can actually interpret and understand the technical requirements that are being asked of the innovators and of the large government contractors to build these systems, right? They're very complex and often they're stuck in the 90s. And I think that's a huge problem for state governments to be able to manage, especially when it's only lawyers at the table who are reading those contracts. You also need software engineers and data scientists and product managers and technical people inside the state government to sit across the table from a Deloitte or an Equifax and say, hey, this price per database query doesn't make sense with my private sector experience, right? Or the way that you're designing this E&E system is unnecessarily complicated and is going to cause all sorts of problems down the road. That's going to generate a lot of billable hours on the part of consultants, right? And so I think the good news is I think CMS has made it clear that 90/10 matching funds can be used to hire technologists in-house inside of government right? So that Nikita and others have a partner in government who can speak, software engineering when they're talking about what a contract might look like, or can actually design a procurement in a way that is not the way that you procure a building or vehicles for a government, but rather how you procure software, which is a very different kind of set of skills. And so I think there's a lot of progress to be made at the state level. And as people look down the barrel of HR1 implementation, figuring out how do we get the right set and right mix of technical skills in-house in government so that we can actually chart a path forward that is intelligent or a responsible steward of taxpayer dollars.
I don't know if you can see this. Maybe, is this book going to load? All right, let me
I
try
can
to
tell by the blur that it's
I know you know exactly what this is. The Bible on this for any technologist, I know Luke and many other folks, whether you're from Code for America or you've worked at, USDS, et cetera. This book, if you haven't read it, is the Bible on how the challenges that states face, leadership face, but the role technologists can play in supporting all of that. So want to plus one, Jen Palka's book, pick it up if you don't have it.
Love it. We often like to think of ourselves as a nerdy book club, and so happy to have another book for us to read. We have about 8 minutes left, and so I want to kind of open the floor to you two to wax a little bit more philosophically. Luke, in your piece, you talked about building public infrastructure as opposed to over-reliance on consultants and vendors like Equifax, and I'm curious to hear from you two. Is there anything interesting or exciting? What are the causes for optimism that you're seeing in the Medicaid space, whether it's at the state level, the county level, with community-based organizations that you would want to kind of highlight today?
Yeah, I'll briefly give a few, but I think just on that kind of bringing in the technology talent in-house, I think increasingly states are really craving that. And I think the fact that there are federal dollars on the table to use towards that end is really very encouraging, right? So I know the Tech Talent Project, which I'm affiliated with, has done a lot of great work to help hire amazing private sector talent to do tours of service inside of state government and inside of state Medicaid programs. That's like a huge opportunity, I think, for states to take this kind of generational challenge of work requirements as an opportunity to build their bench in-house and actually have kind of a durable team that can if it's not work requirements this year, it's going to be something in the next few years, to have folks in seat who can really manage these crises and help build the technology that's going to provide a more dignified experience to people. I mean, there's not a ton to be optimistic about around work requirements, right? Like millions of people are going to lose their health care who are eligible for their coverage, right? Because of the administrative burdens being placed on them. There will be kids who can't go to the doctor, people can't pick up their prescriptions. And it's going to be an enormous burden on state governments. But I think the opportunity to bring new staff in to innovate inside of government and the opportunity to have new companies like Fortuna and others outside of government innovate in the space is sorely needed. And this moment of crisis, I think, might present some opportunities for people to step up.
Agree on the state capacity point that Luke made. Procurement reform and new innovation. I think that's another big one. A third, although in some ways it's connected to, in some ways, state capacity. We saw this a little bit during the unwinding, but the infrastructure for even communicating with enrollees barely existed, to be honest, prior to the unwinding. And now some of the demands of HR1 on data, on tools to provide both agency and just completing, steps that you need to take for enrollees will be improved. So texting was a novelty under a PhD unwinding. Isn't that shocking that states really didn't communicate at all to members that way or to enrollees that way? Started during the unwinding. I'm sure we will see more of that because it has to be a part of successful communications, but it is also an element of HR1 is that there needs to be two types of communications to a household, mail, and then some other form. So I had, there's some optimism related to that in just engaging and making that, providing the state now having some of that infrastructure to be able to engage folks. A fourth one, if I'm, looking for bright spots other than the three I mentioned, is there is, I think, good that comes out of providing resources to folks to find work. To the extent that someone is looking for and seeking ways to, participate in their community or find work. I think there's also some push through, some of the requirements where managed care plans, I know, are certainly doing this. Health systems are standing up ways of connecting people to resources if, based on their current status, they do not meet those 80 hours of community engagement work requirements, or they don't meet an exemption and an exclusion. I think this touches on certain elements of social determinants of health. So things that we've always been doing, but finding now a way through HR1 to continue to invest in that, continue to invest in people having work opportunities, et cetera. I'd say that's another positive and another good thing if we're looking for, a variety of opportunities and positives in a challenging and crisis moment.
And Nikita reminded me of one more that I'm very proud of, and I think is going to be a really important tool, is just the ex parte renewal rates across the country. So ex parte renewals are the process by which you can automatically renew a beneficiary for coverage if you have administrative data on your side, right? So the government knows, Nikita's income and knows Nikita's address, we can renew her Medicaid automatically without kind of forcing an interaction that might be burdensome on her. And those rates after the unwinding went from around, maybe 10 to 20% to over 50% in some months nationwide, which is just like a huge win for the customer experience of being an enrollee on Medicaid, where it is a much lighter lift for an enrollee to stay covered and a much lighter lift for a state and for caseworkers who need to help keep that person enrolled in their coverage. And so I think the ex parte renewal rate being, almost a majority of enrollees for the first time in the past year or two is a huge success. And I am really hopeful that that continues to be a strategy states use to keep people enrolled with minimal burden on them and on their staff, and being a good steward of taxpayer dollars through that process.
This is maybe a bit of a naive question for me to close on, but so 50% sounds a little bit low. If I'm thinking about the information that I might have access to as a state, it's like, well, I'm getting state income taxes from, some subset of people. I am getting addresses. Like, what is the gap there? Like, how do we, like, what would allow that to be higher? And then I guess as a follow-up for Nikita, like, it seems to me like in those cases where there's a lot of edge cases, you need a tool like Fortuna. And so I'm kind of curious to see what the interplay is between those two.
Yeah, you've accidentally hit on my my personal hobby horse, and I know we only have a few minutes left, so I won't go too far. But you're absolutely right to say that the ceiling is much higher than 50%. There are a lot of ways that states can increase that ex parte rate quite substantially, right? Whether it's using income data that they have from their state quarterly wage data that is collected through your unemployment insurance agency, or in the case of work requirements, working with your state's Department of Education to find out who's enrolled in university in your state, right? And in using these kind of data sources that are hidden throughout the state government, finding ways to get that data shared with your Medicaid agency, and then using it to do those automatic renewals. Some states have ex parte renewal rates as high as 80%, right? And that is a huge workload removed off of state caseworkers who would otherwise need to process those cases, and an amazing benefit to beneficiaries who no longer need to get 50 notices in the mail and fill out some complicated packet and call the call center. And it allows the remaining 20%, like you said, who have some change in circumstance where you actually need to have a manual touch. Those people get much better service. They're able to, get through a call center much more quickly. They're able to get to the help that they need in person much more easily. And so it is a huge, I think, strategic priority to increase that ex parte rate as high as possible. And it is possible to get it above 80%. We've seen states do it. It's hard work, but it pays dividends in the long term for states.
Yeah, I agree. There's been a ton of investment in this area. We'll only see more of it. As Luke was mentioning, different data sources that you have available to you, or maybe external data sources that are from private companies that you're contracted with, all of that helps patch up all of the incremental, as many data pieces as possible to hopefully do as many ex parte or automatic renewals or checks as possible. There are challenges because of how you design your data schema is also going to impact how your ex parte rates look. So the schema is, of course, the order of operations that you're pulling that data, but separately, there are variations in how fresh that data is. So some data sources are 6 months old, some are 3 months old, some are more real time. And so that also implicates how good, or let's say, or how accurate your ex parte might be, because if you're using a data source that's 6 months old, it might actually help you with community engagement work requirements because you're doing a 6-month look back, but it might not actually be that person's income data that's correct anymore because they switched jobs or maybe they lost their jobs. So there's a lot of complex architecting, but the work that various organizations that Luke has been involved in on the state capacity and state technologist side, the work that states are doing themselves already, I think all of that layered on top gets us closer and closer to as automatic or as ex parte renewals as we possibly can. And even as a company, we're hugely in favor of that, because as much as you can 80-20 things as possible, let's do that. Let's free up people's capacity to actually focus on the more complex cases, not people waiting on the phone for 4 hours just to get a status update on their case. And that's what a lot of people are doing today, unfortunately. So I'm hopeful that we just continue to see that, because as well, it's a CMS priority to make sure states improve their automations here.
Nikita and Luke, thank you both so much for your time. Really appreciate it, and excited to have you back later on in the year. Hopefully, we can get an update on how things are going and what you're seeing.
Of course. Thanks for having us.
Sounds good. Thanks for having us.
Thanks. Bye.
Bye.